This is a case of lap posterior mesh rectopexy done in 60-year-old male. The patient position is modified lithotomy with steep Trendelenburg and arms tucked at the sides. The port positions are 10 mm umbilical port for camera, two 5 mm working port at right and left pararectal position, and one right pelvic port for retraction. On entering the abdominal cavity, the small bowel loops which are found in the pelvis are gently manipulated and repositioned using atraumatic graspers. Hold the rectosigmoid and keep it retracted in anterior and cephalad direction. Now as we can see here, this is the sacral promontory and this is the right ureter, which is crossing the bifurcation of common iliac artery and lie anterior to the sacroiliac joint. Dissection of right lateral rectum is initiated by cutting right parietal peritoneum starting from the sacral promontory and go towards the pelvis till levator ani. We have to avoid injury to right ureter by staying medial to it. This dissection is being done in the avascular plane between anterior mesorectum and posterior presacral fascia. This right side plane of dissection is extended posteriorly to left side of rectum. Here also prevent injury to left ureter and presacral nerves by not breaching the presacral fascia. The lateral rectal ligament can be cut but remain close to mesorectum to avoid injury to the autonomic pelvic plexus, which is formed by the sympathetic hypogastric nerves and parasympathetic pelvic splanchnic nerves. If they are damaged, it can lead to sexual dysfunction in males, worsening the constipation and urinary symptoms. By using digital rectal examination, we can confirm our lower limit of dissection, which is the pelvic floor formed by the levator ani. And thus we have confirmed that complete mobilization of rectum has been achieved. A 15 cross 10 cm Prolene mesh is introduced into the abdomen via 10 mm umbilical port. The modification used by us is that we have cut the mesh in inverted L shape and it is being sutured to the lateral walls of rectum by using Prolene 20 suture. The lateral fixation should not be covering more than 50% circumference of the rectum to avoid de novo constipation. We have also fixed the mesh to the sacral promontory by using absorbable tackers. The visceral peritoneum of the rectum is also fixed at the sacral promontory by using absorbable tackers. Now in the end, the peritoneum closure is done by using Vicryl 20 suture in continuous fashion. Now it is must so as to avoid contact between the bowel loops and the mesh, which can lead to disastrous complications like mesh erosion. Now we can see the final picture of our modified Wells lap posterior mesh rectopexy. Thank you.